the obvious next step in the direct care movement is bringing our specialists on board. I get that question all the time: is how can specialists engage in the movement? How can direct primary care support specialists in the movement? How can specialists support direct primary care? And so, what are the opportunities to bring surgical or cognitive-based specialists under the umbrella? So, this is just sort of our first step into how do we broaden that tent to allow more people sort of save them from this. So we have a couple fantastic panelists here today. You already met Ellen McKnight yesterday. Elaina George, ear, nose, and throat surgeon in Atlanta, and she is also a national powerhouse. So we're really, really pleased that she could be joining us today. So it looks like we are queued up for Elaina to kick off the festivities. So thank you very much.
Thank you so much, Lee. It's a pleasure to be with you, and it's so nice to know that we're not alone and that this movement is growing. I'm an ear, nose, and throat doctor, and I've been in solo practice for 17 years, since 2001 when I opened my practice. And let's see, how do you do this? Okay. There we go. So, as I said, I opened my ENT practice in 2001, and I've been a solo ENT since then. It's being on the front line because you had to make every single move as fast as you could to stay one step ahead of the onslaught. I'm sure you guys know about the third-party system and how horrible it is. And I think we're at a crossroads. Technically, we've seen a shift in our healthcare system. We're having mid-levels become the front line of care. They are causing us, through the capitation, through managed care, to increase the number of patients we see in our practice. And that's the crux. It's about time. When you don't have the time, you end up just becoming a cog in a wheel and having a conveyor belt mentality, which I personally find offensive, and I decided I wanted to not do that. And we're now in a position again where the doctors and the patients are the insurance companies are trying to pit us against each other. And because you don't have time, they're able to define you. And their patients are thinking of us as the enemy. And the media is putting us on the front line of the reason why healthcare is so expensive, which we all know is ridiculous. I think we make about 7 cents of the healthcare dollar. That goes to the actual physician and the person actually providing the service. The rest is administrative fees and all sorts of things that these guys are not the front line. They're not delivering patient care. They're taking money from us, they're taking money from the patient, and they have the unmitigated gall to make us the boogeyman. Now, I'm from New York originally, and I did everything in New York. And part of my training is old school. That meant that patient history and time was the most important thing. And the actual physical examination was to confirm what you thought. And I loved that style of medicine. I had no interest in tapping on a computer screen, not looking at my patient in the eye and getting them in and getting them out as fast as I could. And during my course of training, I did head and neck surgery at Sloan Kettering, pediatric ENT at New York Presbyterian, general ENT and general surgery at New York Lenox Hill and Manhattan Eye and Ear. And what I found is that over the course of my practice, I've had to shrink what I do. I no longer do head and neck surgery. I no longer see children. I no longer take Medicaid and Medicare because I had to make some hard decisions about, do I want to stay open or do I want to, do what they want me to do and work against the interest of my patients? And this talk is about how you do it, how you craft and carve your niche in a system that's designed to sap your energy, to make you feel like you're not worthy, and to have your patients feel that you're part of the problem. We need to take our power back. Now, private practice is under attack. There's only 30% of us left, so I'm really a dinosaur. I think I'm the only solo practicing ENT independent in Atlanta, which is kind of crazy when you think about it. They want us to be part of a team, part of providers, part of a consortium where we're now becoming the administrators and everybody else is running the front line of care. And I think that's why we've seen the growth of the algorithm, because if you don't know as much as a physician, you're more likely to follow a rule. You know, if it's, we used to say in dermatology, if it's wet, dry it. If it's dry, wet it. But technically, you're just going to follow what the guidelines are. It's evidence-based medicine. No thought, no individualized care, no personal choice. And I think that's sapping, again, our profession, and it's making us unhappy. We do have to take responsibility for how we got here. And I think that they used what's best about a physician against us. We want to help people. We don't want to play politics. We don't want to be business people. We just want to do our job and be advocates for our patient. Sorry, did I go backwards? Sorry, I think I went, I don't know how to go backwards in this. Oh, hold on a second. And our fear. When I first opened my practice, I was told you have to take every single insurance they offer, otherwise you won't be able to stay open. And I fell into the trap. And I signed, like all of us, signed contracts that were absolutely insane. We can get money clawed back forever. They have 2 weeks now in United Healthcare's case to pay us. If we don't submit that claim within 2 weeks, we're not ever going to see money. Contracts like that are completely ridiculous. And because we wanted to take care of our patients, we did it. You know, we just took it. So we've seen the third-party payer system become the focal point. They are now in the business of practicing medicine. They get to decide what's medically necessary. They get to run the show and make the rules. And it's an uneven playing field. I don't think anybody who's talked to an insurance company gets off that phone feeling like they were listened to and that their patient got served. If you actually get an approval, you feel like you won, you know, ran a marathon and you won, because it's so rare that they actually do what they say they're going to do, which is to cover a medically necessary entity, a procedure, an office visit, et cetera. Now you have the ACA, and the government's now put steroids behind this. If we let this go and we get Medicare for all, as we said yesterday, it's going to be a disaster. I actually have a radio show called Medicine on Call, and I interviewed Charles Blahouse. And if you go online and look it up on iTunes, you can hear that interview. It was chilling, to say the least. A 40% cut to our reimbursement right off the bat, and with no end in sight. Every year they can ratchet down what they pay us. And in this system, there won't be an insurance company, because if Medicare for All passes, the insurance companies will not be able to cover what Medicare for All covers. So if they're covering 90% of things, the insurance companies are non sequitur, aren't they? And I believe the way that they'll rope us into this, if Medicare for All passes, they will tie it to our licensure, and they'll make us do this. I think they're not talking about it because people would be up in arms, but how do you keep your workflow? How do you keep your workforce in there? It's always by duress. So if they run the show, they're going to keep us looped into the system against our will if we want to practice medicine. They're already doing things to us, whether that's peer review, whether that's MOC, whether that's making us go through all these expensive hurdles. I thank God I passed my boards. I don't have to do MOC, and I'm licensed for, or my board certified is, you know, for my entire life. I can't believe that we're the only profession that allows other people to define us, and that a lawyer gets to, you know, once they pass their bar exam, they're free. But they want to make us do this every couple of years, spend thousands of dollars, just totally decide our value. I can't believe that our AMA and other organizations didn't fight for us. So this is the problem. I told you a little bit about my practice, about having to limit my scope of practice, about having to do less. And I reached a decision, and it happened here in Orlando, in Disney World, the happiest place on earth. I came to a crossroads. I had to decide for myself. I was crying. I was just miserable. I was like a different person before I made the leap. And I had to decide literally, do I want to practice medicine, or do I want to acquiesce and see 1,000 patients and become a cog in the wheel? And it's just, it hit me that no, nobody gets to define me, nobody gets to decide my worth. I've always wanted to be a physician since I was a kid, like all of you, I'm sure. And to have some third party, somebody decide that you do what we say, we run the show, you have no say in the matter. Yeah, we do. This system does not work without physicians. Can't. And we've given our power to these people. We've decided to play the game because we like to follow the rules, I think, for the most part. We don't like to make waves. We just want to get in the trenches and take care of our patients. And that's what we need to pull back from. We need to take our power back. And one of the things we can do is to open a third-party free practice. Now, I think when I've done a talk on this before, way back in AAPS, and I said a statement that everybody gasped. And I said, the Affordable Care Act is the best thing that's ever happened to medicine. And it was silence, and people were like, oh. But it is, because it put us in a position where we can't play the game anymore. It's like a limbo. How low can you go? We've gone as low as we can go. Now we literally have to stand up and actually say, we put a boundary on this. We're not doing this anymore. This conference and all of you sitting out here are the vanguard. We know our colleagues don't like to lead necessarily. They don't like to make waves. But when we make the waves, it makes it easier for our colleagues to follow us. And when we make the decision to pull away from the system, that's how this changes. It's not the government. I've been up in Congress multiple times, given our information, telling them how hard it is for doctors to practice. And I was told by one of the aides, which is really an eye-opening experience, if you ever go to a congressperson and say, I'm in pain and this is killing my practice and I'm so unhappy, they're actually going to think that they're winning. They don't care. They want this. They think that we are the problem, and they're legislating accordingly. So what we need to do is drive a consumer-driven system, work with our patients to work against this system. All it understands is money and coercion. If we acquiesce, then we're playing their game, and they're winning at it. So having the patient be a consumer is the answer. And that's what I mean by the Affordable Care Act being the gift that keeps giving. When the ACA passed, I had patients literally walk into my office, know that they had to pay a copay or deductible, I should say co-insurance or deductible, and literally walk out because they were spending so much money on their premiums, they all thought that's all they had to pay. Now they get it, and now they're angry, but not at us, thank goodness. It's about the system. And when I go on radio shows and I tell people that it's cheaper to access the healthcare system by using your own pocketbook than it is to use your insurance card, first I got, oh, that can't possibly be. Now I'm like, yeah, I give them my story of what happened to me. So it's now out there that having insurance does not equal access to quality health care. As a matter of fact, it's become a barrier. And the way to get quality health care is to make a contract, a direct relationship with your physician, because that's where the savings are. And frankly, we now have a two-tier system. And we're the part that's good. The people who stay in the system are the ones that are agents of the government, data collectors, metadata miners. They're not about patient care, and I feel bad for them, but it's a choice. And we're the ones providing answers, treatment, answers, time that they're not getting in that system. So it's now our job to reframe the healthcare, or I should say the physician, the medical profession. Everybody else has defined us. We want to cut off feet, we want to take out tonsils. All we care about is our BMWs, and that's not us. It's the CEOs, it's the insurance companies, it's the PBMs, it's not us. And we've been silent and let them do it. Now it's our time. We want to practice medicine using the Hippocratic Oath. I'm not sure the medical students now necessarily take it, but I did. And that's what runs my practice. God, Hippocratic Oath, being an advocate for my patients, that's what's important to me, not this stuff. Being an advocate for my patient and being autonomous is the only way that I'm going to be able to practice the Hippocratic Oath unencumbered. If we don't, we're going to have more compliance, and this system is going to get worse. It's not going to get better. No matter how many times we want to play the game and work with them, they're only going to come back with something that's worse for us. So, my job as a doctor is to be an advocate for my patient. And one of the ways to be an advocate is to be transparent about price and to let them know what their choice is and to be an entrepreneur. My practice is really unique. I said I'm the only independent ear, nose, and throat doctor in Atlanta, probably in Georgia at this point, and it's a good thing. I'm getting patients who are finding me based on my website. We list our prices online. We work with direct primary care practices so that they know that they can send to an ENT who won't break the bank. I've actually crafted a practice that's a lot of office-based procedures. So I do surgery, but it's office-based. Anything from septoplasty, balloon sinus dilation, endoscopic sinus surgery. When you do it in your office, you control the cost. It's under local, actually, not under general, so it's safer for the patient. And if they have an insurance plan, usually it's a copay, so it's saving them money. But because I own my equipment and it's my time, I get to make a deal with my patients, and it's working beautifully. And I've had folks come up to me from Savannah saying that they talk about cash pay with their ENTs, and they get a blank stare. I'm like, I don't get that. I want my money now if I can get it, not a year later or not at all. That's what's been going on in the insurance-based system. So how did I do it? I finally read my contracts, and what was crazy, I left. If they were paying me nothing, and I do all my own billing, so I don't outsource anything. It's all a one-stop shop. When I see my patient, I do my coding. So when the money came back, or lack thereof, I started to see a pattern on these insurance plans, and I got rid of anything that wasn't paying in a reasonable time, not at all, or something that was unsustainable to the practice. I tried to negotiate carve-outs, and that was not as easy as an independent doctor. They only listened to the big players, so that one didn't work so well. But what happened recently, which is really cool, is because I was the outlier, I was the only independent ENT, Wellstar, which is one of the big hospital systems in our city, in our state, approached my office and said, you know, we don't have an ENT in Atlanta or in any of the environments because everybody's locked. They're part of Piedmont system or Northside, and they couldn't see the Wellstar patients. But here I am by myself, and they actually offered me a deal. It's called a clinical partnership. I get to access the Wellstar reimbursement rates, which are 3 times, 4 times what I get paid from the insurance plans now. It's crazy what they get compared to us, completely unfair. But for that, I get to see their patients, but I am not an employee. I don't have to do an ACO. All I have to do is be accessible to their patients. I can take those patients to any other hospital, any other surgery center that I want. I don't have to use Wellstar, and it's a win. So I actually ended up carving out in a weird way a place that I can actually get paid for what I do, still see third party, but through the Wellstar system. So now I'm seeing Cigna, Humana. Humana I left because it was like Medicaid rates. Now all of a sudden it's one of the best payer. So that's one way. If you're an outlier in your system and you know that there's not a lot of you, approach the hospital, say I can be a resource, but this is what I want. And then see if you can carve out a way that way, which is kind of unique but really neat. I got rid of Medicaid and Medicare, I think like 10 years ago. That was the first to go. As soon as they said, well, there was a couple of things. When they were paying consultations the same as they were paying primary care, so you weren't getting paid for consultation, it was a different rate. And then when they said you get dinged for fraud for underbilling, then it was over. So you can't, you're gonna make a mistake. You don't, inadvertently, but you're guilty, and if you do it 3 times, you're not gonna be in practice. Then you add the audits and all the other horrific things that they could do to you. It was an easy call, and I just left it. My practice is a hybrid practice. I do everything. I barter. I have a sliding scale for self-pay patients. I have third-party insurance. And I'm also working with a consortium of direct primary care doctors in Atlanta. It's called Hip Nation. And it's an excellent system. They're paying $100 to see their direct primary care physician, but they have access to specialists, whether that's ENT, whether that's ortho, but we get to charge a cash rate, but we have to be transparent about it. So now I have a stream of cash pay patients coming from direct primary care doctors, so you don't have to send these guys to the hospital and have them be gouged. It's a closed system, and it's cash-based, and it's controlled. So you're not breaking the bank, but the accessibility actually goes up, and that's a really nice thing. So we talked about that. So as we all know, the pros are increased cash flow, physician autonomy, and administrative burden gets decreased. It allows you to significantly increase your reimbursement from third-party payers, and that's the partnership I was telling you about. And I'm not technically an employee, so it's the best-case scenario. The problem is you have to transmit some meaningful use, but I'm an ENT, so all I'm going to transmit is, do you smoke? And have you ever fallen, or do you have any fall risk? None of the, do you have a gun in your home? Do you think your child's a boy or a girl? None of that stuff. So I'm not feeding that beast. But this is what I automatically ask, so I can go 4 times more reimbursement to answer those 2 questions, no worries. Another new thing that I've discovered is telemedicine. And I've been honestly against telemedicine because I didn't like the fact that you weren't seeing your patient and that it was some person calling you up and you were giving advice without laying hands on the patient. I'm, as I said, old school. So I think you should see your patient, you should actually have a relationship. And this company approached me, it's called Carry Health, and it was created by a physician. And it's actually a free platform for doctors, so we don't have to pay a dime to get it. But what was interesting about it is that you can use it for your patients. You can use it as an adjunct to your practice. So you can set the time. If you want to do it on the weekends, you want to do it when you're doing charting notes, then you set the time when they can actually access you. And I'm a surgeon, sorry. So what I want to use it for, and will be using it for, is going over lab reports. Why do they have to come in to go over a culture? But I'm monetizing my time now. We talked yesterday about how you're spending hours charting. You're taking calls on the weekend, and it's all for free. You know, there's nothing wrong. Our time is valuable. Lawyers think about something and they bill it. And we give free time all the time. But this is a way to actually do 2 things at one, have 2 things happen that's good for you and your patient. They want to see you. They want your time. And this is actually something that allows them to actually get it without having to come in to see you. So going over lab is one thing. You've seen them last week. They come back and they're following up. You can actually do a telemedicine consult for that. The fee is something that you can actually arrange, but I think the average is $50 per consult. That's a big difference if you do 2 or 3 of those a week every day. That's a lot of cash that's coming to your practice. And unlike the telemedicine through the EHR, where they're capturing the money, they're using us, as they always do, to be the workhorse so that they can capture the money. And then they can, I'm sure they're going to at some point decide not to pay us for telemedicine because you didn't need to do it. This is completely third-party free. It's a cash-based version, so the patient pays directly to the company. You get the money directly from the patient. No insurance involved, which I think is really very novel. Then they've expanded it so that if you're a solo practitioner, there are other doctors, cloud-based doctors, that actually become a virtual call, consortium. So if you're not around, another ENT can take the call and actually help your patient out. So it's like having a call group virtually, which I think is really cool. As an independent single practitioner, sometimes you're not available, you can't be. This is your fallback. So we talked about the fact that it's expanding your time, monetizing your time, providing access for patients, and allowing you to be a doctor to your patients. It also has the ability, technically, through telemedicine, through digital marketing, to get you new patients. Because under this platform, there's no other patient that can access you outside your state. So someone from California can't call you and then not see you. So this is another marketing, technically another marketing tool that can be used to expand your reach so they can get to know you exist. Patients love it. It's low cost. They're not wasting time leaving their office. It's unlimited consultations. And all the doctors associated with it are board certified. So these are all American trained doctors, board certified. And so there's it's a quality. There's a quality associated with it. You're not going to go below anything. And it now is offering prescription discounts for prescriptions, dental and vision. So it's kind of a one-stop shop for patients who are looking for value, but also are kind of tech savvy. We've talked about HipNation, a little bit more information about them. It's $100 a month to the patient. The specialist, any specialist associated with it has a cash base to their practice. They're listed on their website, so patients can actually see what it's going to cost them before they come and see us. And the most important thing, get rid of the third-party payer. As with anything, it's not for everybody. Nothing's for everybody, and that's what makes our system really good. It's about choice. We're a mosaic. I've heard that mentioned many times, of course, of the last couple days. And it's true, you cannot have one size fits all. That's the problem with the current system. They're trying to put us all into one big pot. They're trying to have one single payer, and then they get to divvy up, and they get to decide the winners and losers. But we make this not a centralized system that everybody can do what they like. The patients win. So ultimately, we have the power, and with our patients, we can actually beat the system. And it comes from us, from the grassroots, from the down up. The government will move when we create a viable and a system that everybody knows about. I think it's really getting out there. People are starting to really get the idea of what direct primary care is, direct pay, cash-based. And the insurance companies now, with Dr. Smith yesterday, it's an eye-opening experience about how that system is built on graft and greed and lying. And all we have to do is tell the truth. We have the upper hand in this thing. Educate your patients and don't be afraid to do so, and know that there's plenty ways to fix this. There's not one way to do it. So as I said, I have this, the first website is for the Carry Healthcare. If you're interested, you can go there and find out about it. HipNation. My show is called Medicine on Call, and it's on all these different platforms. And as I said at the beginning of the talk, Charles Blahhouse was my most recent guest. If you want to know about the Medicare for All legislation and what it would do to the country, that is an eye-opening experience. No drama, just the facts. And I have a website, drelainageorge.com. I write a blog, and I'd love to have everybody give me your ideas, come and converse, because we have to get together. There's no right way to do it, no wrong way, but we need all our voices to be heard. And lastly, I wrote a book called Big Medicine because I wanted my patients to understand how we got to this point. And you can also, if you're interested, get that on the website at drelainageorge.com, because I'm not a big fan of Amazon, and I'm trying to not to give them any money. Thanks for listening.
That was excellent. You know, it's interesting, I was at that AAPS meeting when she said, you know, basically Obamacare is the best thing that's happened to doctors, and there was silence in that room. But to jump off a little bit of what you said, one of the reasons Obamacare, or the ACA, is so important for doctors is because patients are now funding large portions of their health care. And I had mentioned to Dr. George a story from when I started. I began my rheumatology practice in 1993. And at that time, I went into a group with orthopedic surgeons. And I was the only rheumatologist. So I took any insurance that they took. So there was HMOs and all of that. So I was just starting, I mean, within the first few weeks, I would have these patients come in, and there was a rheumatologist who had been practicing in that town for some time, and she was still practicing. And her name was Dr. Flatt. She's retired now. And they would come in and they would say, Dr. Flatt is the greatest doctor I have ever known. I love Dr. Flatt. And after about, I don't know, 15 of these folks, I finally asked this man, and I'm glad I asked a man because he told it to me just like it was. I said, Dr. Flatt is practicing 1.5 miles up the road. Why are you here? And his response was, well, to see Dr. Flatt, I have to pay $25, but to see you, I pay $15. And that has changed so much now because of the ACA and the fact that patients are funding much of their own. They are true consumers, and they are, I'll give you one more quick example. I had an uninsured patient who was seeing me under what I call fair cash prices. So she had no insurance, and at that visit she would have paid me $85. Well, in the meantime, she gets signed up with United Healthcare. She comes in, and so there's a line on the bottom of my sheet, and it was crossed through because she was going to pay $85 cash, and underneath it was United Healthcare, $75. So I tweeted out that day, you know, her visits with me are not really covered, but she's paying an enormous premium as though they were. And that's really what we're up against. That's really the mindset, I think, the change here. Let's see if I know how to use this. Well, how do you get it to go forward? Is it this one? This one, the big one. Okay, here we go. Let's see if
put it on.
Oh, got to get that one up.
Yeah.
Okay, here we go. So I opted out of Medicare. I'm at the end of my 3rd year of opting out of Medicare. I did it for much of the reasons that you heard me speak of yesterday. I have no conflicts. So I actually gave this talk August the 28th to my medical society, and there wasn't a single soul in that room who had opted out. I was literally the lone person, which is really not that uncommon in our real world. And this is just sort of the things that I did. I discussed why I opted out of Medicare. Today I'm not going to discuss the process for opting out. I would just recommend that you go onto the AAPS website. It's aapsonline.org. Everything that you need if you were considering opting out is right there, and it'll make sure you do it the correct way, because there are some ways that you can get into pitfalls. So I discussed some common sense strategies for success. And then basically I want to touch a little bit on the role of social media, and just basically the main reason that I participate in social media is to encourage other doctors. This is really a reach out to physicians more than it is to advertise myself or to be there for the patients. I mean, I do that in my clinic, but I want to bring doctors into this happiness that I think most of us who have opted out feel very comfortable with. So when I went to this group of my medical society, as I said, I looked at them and I acknowledged some things about that group. And I'm not sure the split in this room, but basically most, if not all of the doctors, were actively participating in Medicare and doing it exactly the way that we all participate in Medicare, accepting whatever they pay, putting out, having to do all the regulatory things, and then I said, and most of them are complaining on a constant basis about the perverse incentives and what I call torturous regulations of Medicare. Every single function that you go to, doctors are unhappy. And then I brought this to their attention, which was, and so most of you would have gone through the difficult and costly transition to MACRA and MIPS. And these doctors, and I'm certain anyone who's in Medicare now here would admit that you did it not because you felt it was a true doc fix, or not that you felt it was something that was really going to be good. You did it, most doctors who complied with that and went through all of that, did it to avoid a reduction in the fee schedule, because it was basically said, if you don't do this, you will have a reduction in your fee schedule of anywhere from 1% to 2%, and over several years it would go as high as 9%. And then basically I pointed out to them I had just learned of this new proposal by Medicare to then pay one price for a new visit and one price for a follow-up visit. And in the letter written by CMS Administrative Director, she basically pointed out, there will be a fee reduction for most doctors of what? 1% to 2% and going as high as 9%. So I asked my group and anyone who's still participating, I said, well, do you kind of feel you've been played here a little bit? I mean, they wanted their reduction, and they were going to get it no matter what. And I actually believe that Medicare and the way that they're doing things, which is basically every couple of years they put some massive bureaucratic regulatory nightmare on physicians, and then they threaten physicians and say, if you don't play, we're going to cut your fee, and we're going to call you disruptive, and we're going to come and maybe rack audit you or what have you. So there's this threat. And I view it really as basically, it's like taunting at this stage. It's kind of like they're almost like bullying doctors because they know doctors are going to just go along as we've done for many, many years. So I've kind of come up with, it's sort of like poking the bear, you know. When you think about the different pokes, I mean, I kind of went through this yesterday. I mean, it's MACRA and MIPS, it's ICD-10, it's, you know, you could go on and on. And this bear is depicted as I think that, you know, medicine really is, which is sort of docile and dormant and not able to do anything. And I've just wondered, you know, when are we going to growl back? When are we going to growl back and say, you know, and maybe stand up in this posture and say, you know, get out of my exam room already. I mean, I'm really tired of these things. So that was kind of the essence of what I brought to them. And the original poke was this, when I say poke the bear, because basically we should educate our patients that the original Medicare law promised to never interfere with the practice of medicine. The government reneged, not doctors. And if you look down here, it's prohibition against federal interference. And then when you read that paragraph, they basically say with anything. They mean payments, they mean your diagnosis, they mean your treatment plan, and that was the original poke because they certainly didn't comply with that in any way, shape, or form. And the other one down here at the bottom is free choice by the patient, guaranteed, meaning in other words, the patient can see whom they want when they want. And I don't think we're living under that either. So that was the original poke. I guess we didn't realize it back then. So I mentioned this yesterday, that we were in this consequential dormancy, and these are the pokes. You see MACRA, MIPS, third parties, Medicare interference, HIPAA, RAC, and all of that. And every adverse condition that's forcing us kind of to be dormant is driven by Medicare. I mean, insurance companies follow, but Medicare leads the way. So they're sort of like the, you know, the ultimate overlord. They're the overlord of overlords, to get to the point from yesterday. And of course, the main reason that I chose not to go this route, or to kind of come out of the Medicare system, is I didn't want to be on the electronic health record, you know, in the way that they want you to be. I didn't want to be, I have a home life that I cherish, and I didn't want to be at home doing all these things that I considered meaningless to me. And so basically they incentivize doctors to take their eyes off their patients and focus instead on the computer. That was unacceptable to me, and it results in our skill and training not being used to diagnose and treat our patients. Instead, we're doing all of this irrelevant, you know, junk data entry, and we all know the routine here. I believe the EHR and all of these government mandates are the main contributor to physician burnout, and that's why we need to quit doing it. We need to, reclaim get our happiness quotient to rise, and this is one way to do it. So this just points out that 1 hour with patients, 2 hours with EHR clerical work, so that was an unacceptable option for me. My husband actually made this slide, which I think is great. It will be of little avail to the people if the doctor's notes are so voluminous that they cannot be read, or so incoherent that they cannot be understood. So that was originally meant for the laws of this land, and as we know, things like the ACA are omnibus bills. I mean, James Madison had it right, but I actually think it really, really can actually pertain to the doctor's note. So this is something I tweeted out in 2016, and basically when a picture tells the story today's doctor-patient relationship, and they're all sitting at a computer, these are young doctors. I mean, this is just, so I put up there, what a waste of a great profession, hashtag ditch the EHR. I mean, this is just unbelievable, and again, I consider I know this room believes that this is unacceptable, and that's part of why we are all here. So just to make the clarifying point that I actually have computers in my room, I'm not going with paper charts from room to room. I'm about to do an upgrade on my Macs. I use something, it's Mac Practice Office Management System, which is phenomenal. But I've developed kind of a charting system that works for my rheumatology practice, and I absolutely love it. I just wanted to put this up there because I'm so proud of it. This is my opt-out letter from Medicare acknowledging that I opted out, and that it was, well, you can tell how inefficient they are. I mailed this, I don't know, sometime in early October, because I believe that's when IC-10 was going to hit. Was it October 15th, 2015? I wanted my letter to land the day that ICD-10 hit. I wanted someone at Medicare to open it up. But look how inefficient they are, because on January 12, 2016, that's when I get the letter saying that my Medicare opt-out is effective for January 1, 2016. So it kind of goes to the inefficiency of this, this group. So if you're thinking about opting out, you want to, again, go to AAPS for step-by-step, but you're going to begin 6 months in advance. I actually think if you can time it starting in January, where your opt-out is January 1, because people are used to paying cash in January because they're used to meeting deductibles. It's a really good timing if you can work it out that way. And then you want to make sure that when you send in your opt-out affidavit, that you request that they acknowledge that they've received it. By sending, you want to send it like certified mail, and that they've received it. You want to know that they have. And then you also want to develop, I'm in a very small practice, so this was not an issue for me, but once you opt out, you don't want anybody mistakenly sending a Medicare claim. So you want to make sure you develop some policies. So I tweeted this out on my first day. It was the first day of the rest of my medical life. No Medicare bureaucracy allowed, but Medicare patients are always welcome. And then I realized later that day, I opened my mail, and this is in there, which is a CMS, whatever they send. And I said, well, the least appreciated benefit of opting out of Medicare is unsubscribing to CMS's endless emails. And that's worth it right there, honestly. So the step one, I'm going to go through what I kind of did, and hopefully this will be helpful. So actually in 2010, now remember my opt-out was January 1st, so in 2010 is when I quit accepting new Medicare patients. And I had started this new practice. I had been with the orthopedist for 15.5 years, and then I went into my new practice in 2009. So for 1 year, I took any and everything. And then in 2010, I stopped accepting new Medicare patients. And I didn't ultimately opt out till 2016. So the reason for that was that with their email stream, Medicare kept warning me and telling me, they were not even hiding it, that if I didn't comply with all of their things, that by, it was either 2015 or 2016, they were going to start penalizing me. You know, as they do. They were going to penalize me for not doing the EHR and all these things, which I had already determined I wasn't going to do. So I went ahead and opted out, quit accepting new Medicare patients in 2010. However, even if you're contemplating this, now's the time to try to change this milieu. If you're thinking, well, maybe it'll be next year, or you're going to opt out January 2020, whatever it is, you need to consider doing this and begin changing the milieu of your practice. So I actually did this, and again, there was no guidance for me. No one in my city has opted out of Medicare for the most part, so I did some things on my own. I had decided that I would institute an annual service fee. Now, if you look at the bills you pay in your practice, almost like your shred, when they come to shred your documents, there's a service fee. When you get things mailed to you via, some of the pharmacies that mail things to you, there's a service fee. Everyone out there has a service fee, and I thought, you know what? I'm going to do a service fee. Now, I got this idea from a family practice doctor in our town who did it. And so I have put things on there like prior authorizations, but I've also put all sorts of things on there. Filling out things like handicap paperwork, copying labs, calling in after hours prescriptions. It's all included, because you can't include only prior authorizations, because I think the insurance companies, so you just have to list, and I have a list of this if anybody's interested. So I do 35 per patient and 45 per family. I lost no patients over this, except for one couple. They were a Medicare couple, and they did not stay. But actually, when you think about it, if they weren't going to stay for this, they certainly weren't going to stay for my ultimate opt-out decision. So it was probably okay to fill in that slot. The other thing I did was I wanted to make sure that my patients couldn't come back to me and say, Dr. McKnight, you gave us no warning of this. And so I'm thinking maybe 2 years before I ultimately opted out, you do that almost once a year paperwork thing where people have to re-sign things. So I had him sign what I'm going to call an acknowledgement statement. I acknowledge that I have been made aware that Dr. McKnight chooses not to participate in certain Medicare mandates, including the EHR and meaningful use. She will be penalized by Medicare for not participating, and those penalties will increase each year. She will continue to be a Medicare provider, as long as it's feasible. And they initialed it. And so, therefore, no one could really come back and say that they hadn't, because that was kind of in the pipeline. And while they signed that acknowledgement statement, I had them sign this acknowledgement statement, which I actually still have them sign, something along this line, which basically said that they've been made aware that I actively participate in CME programs as a mechanism for staying current. She complies with the Florida State Board of Medicine and has been licensed for over that many, 20 years plus. But she does not participate in maintenance of certification or time-limited certification exams. And the reason I did this is because if you go on my Twitter, I have hashtag, I'm basically proudly boycotting MOC. I think it's ridiculous. Dr. George pointed out. And so one of the things that ABIM says is that patients are clamoring for this. Well, if every doctor in America had their patients sign an acknowledgement statement like that, it would be very powerful to say, my patients are aware of this. And no one walked out and said, I have to see someone who is certified by ABIM, not a single one. So this one I did not lose anyone over. So I'm going to give you what I kind of devised and came up with. I call it fair cash pricing. And so the goal here, I treat chronic illness. So the goal is to incentivize chronically ill patients to be seen on a regular basis in the clinic. So I based it on, now this is for established patients, I based it on 12-month intervals. And so now this was what I put forth in 2016. And I will make this point to you. Figure out whatever your bottom line price is and put that out there and then keep it that way for the second year. What you do not want to do is start raising your prices right after the first year, because I believe that patients will go, oh, I see what this is about now. It's going to just get higher and higher every year. So figure out those prices, look at it hard, and figure out what you need to stay open, bring home some money for the first year, and then don't raise it the second year. All right, so anyway, in my case, it was pay-as-you-go. You can do a pay-as-you-go option, $90 for the first visit, and then $85, $80, $75. And then I'll see you as many times as you needed to be seen for $75. So in my world, if I'm seeing you frequently, it's easier for me, because these people have complex medical problems, but if they were only seen 6 weeks ago, I know what's going on with them, so that visit is just not as difficult. And so now what I've done now, in the third year, I did raise this. So it's $95. I don't even want a $100 office visit. I just don't want. I'm going to really try to not have that. So it's $95, $90, and then the floor is $80. And again, I'll see you as many times. And you can prepay. Because I have some patients like methotrexate checks who we pretty much see every 3 months. So with that, you can prepay. So in the original incarnation of this, it was $300, and you would get 4 visits. Now, if you didn't make the 4 visits within a 12-month period, and I'll reschedule you if you have a problem, but if for whatever reason you didn't get in, well, again, I'm incentivizing compliance. You were not compliant, and that's basically, you're not refunded that money. So you must use all the visits in the 12-month. And then I kind of discourage people from staying away, because that does make it more difficult for me. And again, I'm trying to incentivize people to get the care for their chronic illness. So if you stay away, it gets more expensive all the way to a new patient price. And those have come up a little bit, but I don't exactly remember what they are. So my new patient price is $225. I did raise that to $235. But things have been going very, very well. And one of the things Keith Smith said yesterday was that he goes and he starts lowering his prices now for procedures. That's the only thing he enters. He enters new procedures and sometimes lower prices. And I thought, you know what, maybe I'm going to decrease this hurdle to get new patients in. So, and I do charge extra for shots and injections, because I don't have a direct care practice. So some of this stuff is extra, but I try to keep it reasonable. And then all patients paid the $35. And for the first time in my life, I had to do a no-show fee because patients who are paying cash, they feel better. You know, they were just in with a big flare, they feel better. They don't want to come in. Now, in my case, I tell them, I need to see you post-flare because, number one, I need to make sure your definition of flare meets my, or of improvement meets my definition of improvement. And then I want to have that opportunity to talk to you about why I think you might have flared. Did you stop your Plaquenil, for instance, or something along these lines? So one quick thing, when I opted out, I realized Medicare patients are overtly penalized. They have no option. If they see an opt-out doctor, they can't go to Medicare and present to Medicare what they paid me and expect to get something back. So I brought this resolution, which did pass at the Florida Medical Association. I'll just jump to the you know, sort of the point, which was that basically to have a change in federal policy, that the FMA supported a change in federal policy which would allow a Medicare patient who sees an opt-out doctor to potentially get something back from Medicare. I'm going to go on through these very quickly. I wanted to just mention a little bit about social media. We do need to stop telling younger generations not to become doctors. This room especially, we really need to be singing that song. And I would like to see experienced doctors not retire early or not sell out to the hospitals, but to decide, you know what, I'm going to opt out, I'm going to offer fair cash pricing, I'm going to promote privacy and access, and see how it goes, and love medicine again, and want to stay in it. Just one quick thing, that when I checked this earlier this year, there were 24 opted out rheumatologists, and there I am at number 16. And then this, when I checked it out, were the family practice doctors that were opted out was about 1,200, and then if you added on to that internist, it was about 2,000. So I suspect that number's even larger now, and we want to make that grow. And then I'm going to go past this, I'm going to go past that. At some point, if you want to ask me, this is the quality reporting measure. I just will say that I have a 0 on that. And I'm sitting here smiling because I didn't think I'd ever thrilled to get a 0, but I absolutely am on this. And so the tips for future opt-out, learn about and encourage, not that I have to tell this group that, this is what I told my medical society, direct care and fair cash pricing models. Don't disparage it right now, even if you don't feel it's for you. We need doctors becoming more independent. It helps all doctors if we're doing that. I'm not an attorney, but I'll mention this quickly in case it ever does come up for anyone. I wondered if you're a hospital-employed doctor and you say, I want to leave this practice, this situation, and I'm going to go third-party free, but the hospital is all in on Medicare, Medicaid, insurances. Are you really competing with them? And could you make the claim that I'm not really competing with you because I don't take any of those insurances? I think it's a good question for somebody who knows those types of things. Limit your new Medicare referrals into your practice, get on social media, and become an activated doctor. And I'll just go with this one. I'm going to go to right here. I have fun on Twitter, and I get, like, this was off the Beatles song, you know, get back to where you once belonged. The bedside, diagnosing and treating, our doctor's orders honored, doctor-patient confidentiality, private practice, direct care, lifetime board certification, CME for continuous learning, defending our profession, and loving medicine again. I think that's it. Thank you very much.